Good day. Today, I will be discussing about the armamentarium used in dental anesthesiology. These are the local anesthesia armamentarium. They are the syringe, the needle, and the cartridge. So, types of syringes. The non-disposable. It is a side and basal loading, metallic, cartridge type, aspirating or non-aspirating. And second one is the pressured syringe. It is used in IL injection techniques, especially in mandibular teeth. So there are types. So the pistol grip and the pin grip. So the jet injector needles. These are these images shows the jet injector needles. So specialized syringes. For the intraosseous syringe, it is a narrow and surgical drill that needed. So this image. The syringe components, so needle adapter, piston with harpoon, syringe barrel, finger grip, and thumb ring. American Dental Association, or the ADA, criteria for acceptance of LA syringes. So 1. Durable and sterilizable or packaged in a sterile container if disposable. 2. Accept a wide variety of cartridges and needles of different manufacturers, universal use. 3. Inexpensive, lightweight, and simple to use with one hand. 4. Provide effective aspiration and the blood be easily observed in the cartridge. Then the incidence of positive aspiration may be as high as 10% to 15% in some injection techniques. Assembling the syringe system. So, ensure syringe has been sterilized, ensure the needle container seal is intact, break the seal by rotation, screw needle to hub, check the LA cartridge contents, the expiry date, cloudiness, cracking, and the air bubbles. Load the syringe with cartridge and ensure free flow of LA. Holding the syringe. So hold the barrel rest with the index and middle fingers of the dominant hand and the thumb rest with any part of your thumb. The syringe should be below the vision level. The other hand, dental mirror, should reflect and stretch the mucosa and identify the landmarks. So as you can see in the images. So dismantling the syringe system. So remove needle either by needle forceps, finger protector, single-handed pick up. Disposable syringe has a built-in needle guard. Place the needle and the glass cartridge in labeled sharps container, orange. Return the syringe for washing and autoclaving. The needle gauge. So the larger the gauge, the smaller the internal diameter of the needle. Usual dental needle gauges are 25, 27, and 30. The length is 1. Long approximately 40 mm, 32 to 40 mm for NB, and 2. Short 20 to 25 mm. Third one is the extra short, approximately 15 mm for PDL. Components of the needle: bevel, shank, shaft, hub, syringe adapter, syringe penetrating end. The cartridge components: cylinder, plunger, diaphragm, in types standard, self-aspirating, plastic, and glass. Contents: LA, VC, vehicle, and preservative. Its volume is 1.8, 0.2, 0.00, and 2.0 ml. The cartridge. So these picture show the cartridge. So as you can see, these are the types. You can see the aluminum cap, the neck, the rubber diaphragm, the silicone rubber plunger, the cylindrical glass tube, plunger indented from rim of glass. The cartridge should not be autoclaved, stored at room temperature 21 degrees Celsius to 22 degrees Celsius, 70 degree up to 72 degree Fahrenheit. So should not be soaked in alcohol and should not be exposed to direct sunlight. The packaging. Contents of cartridge: anesthetic agent, vasoconstrictor, preservative for vasoconstrictor, sodium chloride, and distilled water. Loading the syringe: remove syringe from sterile bag, attach needle, retract piston fully, insert cartridge, engage the harpoon, and carefully remove the colored cap. Do not pass needles and sheath head, and use a mechanical recapping device. Do not recap needles using two handles. Use a one-handed scoop technique. Other armamentarium. So topical anesthetic strongly recommended. Ointments, gels, paste, sprays. Second one, the applicator sticks, and third one is the cotton gauze. So topical free nerve endings. The terminal nerve endings, the infiltration, and the main trunk nerve block. Dentipatch, lidocaine, tenso-oral delivery system. So pre-injection, 10 to 15 minutes exposure prior to injection. Root scaling planning, apply 5 to 10 minutes prior to beginning procedure. Here. So the contents of cartridge, the anesthetic agent. The ideal local anesthetic, so water-soluble, stable in solution, non-irritating to nerve, low systemic toxicity, short induction period, adequate duration of action, no post-anesthetic side effects, vasoconstriction effect. The percent solution. Different anesthetics come in various concentrations. These concentrations are given as a percentage. 5% to equal to 5 mg cc, 1% equals to 10 mg cc, 2% equals to 20 mg cc. Multiply by 1.8 cc to determine how many milligrams are in a dental cartridge. Chemical configuration of local anesthetic compounds in dentistry, the amides and the esters. Amides versus esters. So major differences is method of metabolism. Amides, majority of the drug is metabolized in the liver. Use with caution in patients with severe liver disease. Use lower dose to avoid toxicity. Esters, metabolized in the plasma by pseudocholinesterase. PABA is a major metabolite of ester metabolism, known allergen. Typical pseudocholinesterase deficiency. Patients will not be able to metabolize, toxicity may ensue. Amide local anesthetics, the articaine, bupivacaine, etidocaine, lidocaine, bupivacaine, prilocaine. Ester local anesthetics, the butyrcaine, benzocaine, cocaine, chloroprocaine, hexylcaine, piperocaine, procaine, proxicaine, and tetracaine. Nerve conduction. Resting membrane potential, negative 60 to negative 90. Stimulus, slow depolarization. Threshold reached causing action potential. Repolarization. At resting potential, axoplasm is negative, around negative 70 MV. Membrane is fairly permeable to K plus and Cl1. So membrane is only slightly permeable to Na plus. Nerve excitation causes increase in the permeability of the membrane to Na plus. The rapid influx of Na plus to the interior of the nerve cell causes the axoplasm to become more positive. The firing threshold is reached, negative 50 to negative 60 MV. An action potential is created. Repolarization. At the end of the action potential, the electric potential is positive, positive 40 MV. The nerve membrane becomes impermeable to Na+. There is an influx of K+, and there is a return to normal resting potential. Mechanism of action of local anesthetic agents. There are different unproven theories to explain the exact mechanism of action of local anesthetics. The basic fact is that sodium channels are blocked, preventing sodium ions from crossing the membrane. This causes blockage of the formation of an action potential. Henderson-Hasselbalch equation. It determines how much of the local anesthetic will be in a non-ionized versus ionized form, based on tissue pH and anesthetic pK. Henderson-Hasselbalch count. So injectable local anesthetics are weak bases, pK 7.5 to 9.5. When a local anesthetic is injected into tissue, it is neutralized and part of the ionized form is converted to non-ionized. The non-ionized base is what diffuses into the nerve. Henderson-Hasselbalch. Hence, if the tissue is infected, the pH is lower, more acidic. So, and according to the HH equation, there will be less of the non-ionized form of the drug to cross into the nerve, rendering the LA less effective. Once some of the drug loss occurs, the pH in the nerve will be normal and therefore the LA re-equilibrates to both the ionized and non-ionized forms. But there are fewer cautions which may cause incomplete anesthesia. Factors affecting LA action, so lower pKa, more rapid onset, more LA in non-ionized form to diffuse through, increased lipid solubility, it is equals to increased potency, increased protein binding equals to longer duration of action. Maximum recommended doses of local anesthetic shows here. Vasoconstrictors constrict vessels and decrease blood flow to the site of injection. Absorption of LA into bloodstream is slowed, producing slower levels in the blood. Lower blood levels lead to decreased risk of overdose toxic reaction. Higher LA concentration remains around the nerve, increasing the LA's duration of action. Minimize bleeding at the site of administration. The naturally occurring vasoconstrictors, the epinephrine and the norepinephrine. Vasoconstrictors should be concluded unless contraindicated. So, mode of action. Attached to and directly stimulate adrenergic receptors, act indirectly by provoking the release of endogenous catecholamine for intraneuronal storage sites, combination of 1 and 2. Epinephrine, the adrenaline, most potent vasoconstrictor used in dentistry, concentrations of 150 to 1 to 100,000 in dental cartridges. Vasoconstrictors, it's unstable in solution. The sodium metabisulfate added known allergen. So please remember, Principle 1, no drug ever exerts a single action. Principle 2, no clinically useful drug is entirely devoid of toxicity. Principle 3, the potential toxicity of a drug rests in the hands of the user.